Good evening, ladies and gentlemen, honorable professors, my fellow colleagues and students. Welcome to Oral Diagnosis and Maxillofacial Radiology Society's webinar series. I'm Dr. Mert Atapek from Yeditepe University, and I'm honored to host this evening's guest lecturer, one of the greatest names of our proficiency, Professor Dr. Ingrid Rozylo Kalinowska.
Thank you.
She's from Lublin Health University in Poland and a former ODMFR president. She also have a seat in junior ODMFR's committee and research committee. She is well known around the globe. Without further ado, let's welcome dear professor. You look lovely.
Çok teşekkür ederim.
You're welcome. You may proceed. Thank you.
Sağ ol. İyi akşamlar. Davetiniz için çok teşekkür ederim. Ben çok memnun oldum. Başlangıçta kendim hakkında birkaç söz söyleyeceğim ve prezentasyonu şimdi paylaşıyorum. Bir dakika. Bundan nefret ediyorum gerçekten. Okay. Peki. Ben Polonyalıyım. Lublin'de oturuyorum. Lublin burada. Lublin'den Ankara'ya yürüyüş yapsaydım en az 400 saatlik yolculuk yapmam lazım. Ve ben Lublin'deki diş hekimliği fakültesinde çalışıyorum, yardımcı dekan olarak. Aralık ayında Profesör Dr. Kaan Orhan misafirimiz oldu ve bu fotoğrafta biz beraberiz. Baş dekan Profesör Renata Hałas, ben tabii ki, Profesör Katarzyna Sarna-Boś ve Profesör Jarosław Sobieszczański. 2020 yılında biz yeni bir binaya taşındık ve bu binada modern klinikler var. Benim bölümüm de var ve orada röntgen makinesi, konik ışınlı bilgisayarlı tomografi makinesi ve ultrasound cihazı var. Öğrencilerimiz de tıp simülasyon merkezinde pratik için çalışıyorlar. Merkezde yeni haptik simülatör var. Ben Türkiye'yi çok seviyorum. Türkiye'ye 19 kez gittim. Ama hem iş hem tatil için gittim. Covid salgının yüzünden bu defa sizinle olmak internet bağlantısı kullanıyorum. Fakat bile Polonya'dayken ben kendimi Türkiye'de gibi hissediyorum. Ben Türkçe müziği dinliyorum ve mesela Türk dizi seyrediyorum. Bugünlerden pek boş zamanım yokken sadece 4 farklı dizi izliyorum. Yine de Türkçe konuşmak bana hala çok zor geliyor. Bu yüzden bugün İngilizce'de devam edeceğim. Gelecekte dersim Türkçe'de vereceğim söz. Ve amacım bu. The aim of this presentation is to present current status of imaging diagnostics of paranasal sinuses, and as says, this is also my goal to be able to lecture in Turkish one day, because I do know that there are so many friends, very close friends, arkadaşlar, dostumlar, who are in Turkey, and I would like to be closer to you, not only via internet, but also with my heart and my soul. In my presentation, I would like to shortly present an overview of diagnostic imaging methods that are available for imaging of paranasal sinuses, and also to discuss some pros and cons of these techniques. Then I will briefly remind you of the anatomy of the sinuses, give some examples of pathologies, and then continue with probably the future of diagnostics. So for diagnostic imaging modalities that are available nowadays, we still use X-ray studies such as radiographs, CBCT, and medical CT. And so we can also use the methods which are not based on ionizing radiation, thus harmless to patients, which is magnetic resonance imaging and ultrasonography. For radiodiagnostics, on one hand, the dedicated sinus views, such as Waters' view, which is occipital 0 degrees, taken with open mouth for sphenoid sinus, linear or spiral tomography in coronal sagittal plane, through lateral of the skull or submental-vertex radiographs, they become obsolete. In fact, I also found a statement saying that radiographs do not have any more use in diagnostics of paranasal sinus disease. However, in dental maxillofacial radiography, we are in a little bit different situation because the radiographs that the dentists take for different reasons, also for dental pathology, they show us at least a little bit of paranasal sinuses. That's why we must possess some knowledge about paranasal sinuses. If we are dental maxillofacial radiologists, of course, our knowledge must be more in-depth, but even general practitioners, dentists, they must know a little bit about the sinus because you can see it in periepical radiographs, especially when alveolar recess of the sinus is very deep. Also, panoramic radiographs demonstrate large portions of sinuses, but we must always remember that this is just tomographic radiographs, so some lesions in paranasal sinuses may be located outside the main focal plane of panoramic radiograph, therefore we do not get complete information. Still, panoramic radiograph allows comparison of both sides, and if, for example, on one side, and the panoramic innominate line is erased together with radiopacity of the sinus, this should warn the dentist of possibility of maxillary sinus cancer and refer the patients for further imaging diagnostics. As mentioned, nowadays Waters' view radiograph are rather obsolete. In fact, I started my journey in radiology back in 1997, and at that time I worked mostly with maxillofacial surgeons. Since 2007, I've been working in the dental school, so with oral surgeons and all other specialties of dentistry. But at that time, for 10 years, I've been working in the Department of Medical Radiology and reporting studies for maxillofacial surgery. And a lot of radiographs were taken, including Waters' view. Now, we don't take these ones anymore. Please take a look at the study in 2002, so 22 years ago, the conclusion of comparison of Waters' view with medical computed tomography yielded in the conclusion that the Waters' view has its limits in the diagnosis of sinusitis of the maxillary sinus, and its contribution for diagnosing lesions in the remaining sinuses is very poor. So already almost 25 years ago, medical CT was recommended for imaging of sinuses. I found a much newer paper published in 2021, and the authors focused on combination of panoramic imaging and Waters' view. And the inter-observer agreement was good for Waters projection, well, let's say good, 0.765, but it was very poor for panoramic radiographs, just 0.281. And the conclusion from this study was still that panoramic imaging was equivalent to Waters projection for diagnosis of maxillary sinusitis, but combination imaging comprising panoramics and Waters projection can contribute to diagnosis of odontogenic maxillary sinusitis. However, it was a study only about sinusitis, not about tumors and other lesions. And of course, we must always take into account patients' benefit from the dose of radiation. And sometimes if we count the dose from individual radiographs, we may end up with one cone beam CT with comparable or even lower dose that will demonstrate much more information than plain radiographs. Talking about radiographs, also occlusal radiographs of the maxilla will demonstrate us some portions of sinuses. So once again, I do not recommend this radiograph as radiograph of choice for imaging of paranasal sinuses, but if sinuses are visible in this kind of radiography, of course, they must be reported as well. I also do not recommend taking lateral skull views for sinuses because the images of both sides overlap on these radiographs. But again, cephalometric radiographs taken so very frequently by our colleagues orthodontists and also in orthodontic surgery, they do show the sinuses. So please remember to report also sinus findings and do not use this radiograph just for cephalometric tracing. For linear or spiral tomography in coronal and sagittal plane, before the onset of cone beam CT, some panoramic machines were equipped with this kind of tomography, but now it's not used anymore. And of course, it's because of this great popularity of cone beam CT. And this is no wonder, because with a simple examination, with one even not complete rotation of the X-ray tube around patient's head in conjunction with image detector, we get different sizes of volumes from small, medium to large. Of course, in order to diagnose paranasal sinuses, we would go for the large field of view when indicated, but as always, small fields of view can also include some portion of maxillary sinus, and the findings must be reported. So CBCT is very versatile too, because provides a large selection of field of view from very large to very small with high resolution, and we must always balance the indications between the high resolution and low resolution. And in case of sinuses, this resolution can be lower than in case of endodontic diagnosis, because we don't need really hundreds of images per sinus to diagnose mucosal thickening or mucus retention cyst. It's the opposite with endodontic teeth, or like in this case with inner ear, when we have to diagnose very tiny structures with high precision. Of course, CBCT with adequate field of view will demonstrate all paranasal sinuses. Multiplanar images allows us to demonstrate lesions in three main planes. And in CBCT, which is like halfway between radiographs and medical CT, we can evaluate mostly bone, but also soft tissue as shadows, but not with the same precision as in medical CT, as the estimation of Hounsfield units, the density, optical density in CBCT is much less precise than in medical CT. And let's move on to computed tomography with current machines with spiral scanning, multiple rows of detectors, one source of X-ray beam or two sources and dual source machines or dual energy machines with one tube but different energies of peak kilovolts of a machine. CT became also very popular imaging modality in medicine, of course, but also in ENT and in paranasal sinuses. The benefits of CT includes also the choice of field of view, which can be limited to maxillary sinuses or encompass all the sinuses. So all walls when adequate field of view is chosen. And as already mentioned, the measurements of Hounsfield units allow us to differentiate between hard tissues and soft tissues, and measurements of Hounsfield units before and after administration of iodine-based contrast medium also provides us with information on the vascularization of the tissues, and this way more precise differentiation of lesions. As far as soft tissues are concerned and differentiation of lesions made of soft tissues, MRI is far superior to both CT and CBCT for that purpose. And one of the advantages of MRI is that the patient is placed into strong magnetic field, which is considered harmless to human beings, at least, and the doses, let's say, during the examination for the patients. And with magnetic resonance imaging, the external electromagnetic field makes the protons of hydrogen align according to the external lines of magnetic field. And then we've got the overall magnetization vector of the nuclei of hydrogen, which is so prevalent in human tissues. That's why it was chosen for MRI, as hydrogen protons are present in water, which is the main component of human body, but also in organic and inorganic compounds in our body. So once the protons in the scanned area are aligned according to the external magnetic field, some of the spins of the protons will be aligned in the opposite direction, but still a net vector will be produced. And the next step in MRI is to use an external pulse of radio frequency that changes the magnetization from longitudinal to transverse. And once the pulse ceases, the protons relax, so they return to the original longitudinal magnetization, and the possibility of differentiations of tissues with MRI is based on different times of relaxations of the protons. Of course, these times are very short, like milliseconds, and that's why the RF pulses must be repeated several times during examination, hundreds of times, but still this provides us with very high quality imaging of paranasal sinuses with different planes like sagittal and coronal are one of the most useful in case of paranasal sinuses, and also T1 weighted images before and post contrast enhancement with gadolinium-based compounds, as well as T2 images, and also some special sequences like fat saturation, for example. And MRI is useful not only in demonstration of the just sinus pathology, but it's also useful in imaging of cranial extension of tumors, so perineural spread of malignant tumors of the head and neck. One of potential disadvantages of MRI is that in general, tissues that do not have too many protons, like the very dense tissues of teeth or cortical bone that does not contain a lot of water will not produce signal in MRI, but we can still diagnose bone on the basis of the image of a bone marrow. I promised some evaluation of different imaging methods. So this is one of them from 2020, a review of imaging of paranasal sinus infections in children. And the conclusion from the study was that CT is excellent for determining whether there is intraorbital extension of paranasal sinus infections. However, when the infection approaches orbital apex, magnetic resonance imaging will be superior to CT in demonstration of cavernous sinus and intracranial connections of the inflammation. For comparison of MRI and sinonasal disease in relation to CT, a paper published in very highly ranked European Journal of Radiology concluded that MRI can add value over conventional CT evaluation of the sinonasal spaces. Specifically, MRI can provide insight through better depiction of the anatomy of certain sinonasal subsites, including the olfactory structures. That's why it's also very useful in evaluating anosmia, fungal sinusitis, tumors, both benign and malignant, as well as cerebrospinal fluid leaks and pathology extending into sinuses. And last but not least, ultrasound, which uses physical properties of acoustic waves with a frequency over 20,000 hertz. So this is what bats and dolphins use for echolocation and also man-made submarines. We've got a large variety of ultrasound units, and the benefits are that the examination is again harmless to patients as is based on acoustic wave. And owing to big differentiation of machines from small portable ones to large, very fancy and very expensive with elasto, etc., it can be used in different settings, clinical settings, at home, in the area of car accident, etc., etc. But is it really useful for paranasal sinuses? The first and one of the very few reports that I found dates back to 1992, when a B-mode ultrasound was compared with CT findings. And the results were quite promising at that time, 30 years ago, as frontal and maxillary sinuses were examined with traditional sonographic technique and ethmoids with transglobe technique. And for isolated mucus retention cysts and focal mucosal thickening, the authors found that the sensitivities for ultrasounds for maxillary frontal and ethmoid sinuses were 100%. And also the specificity was very high. I would like to underline one piece of information. The trial comprised of only 41 patients. And since there are not too many papers on the use of ultrasound in maxillary or other sinus diagnosis, it means that during 30 years, not much has changed. And in this systematic review of test accuracy in diagnosis of acute rhinosinusitis, we've got comparison sensitivities for different imaging modalities. And the highest, no surprise, it's for computed tomography, also high for AP radiography. But for ultrasound, especially for B-mode ultrasound, the sensitivity is only 0.5. Okay, so we went through the overview of diagnostic imaging methods. Now a very short look at the paranasal sinus anatomy. I think that everyone knows how many sinuses they are, and that they are of large importance in dentistry. The main ones are, of course, the pyramids shaped maxillary sinuses. And also for anatomy, one of more important issues are the passages into which the paranasal sinus is empty, because any blockage of the flow of mucus from the sinuses will result in congestion and in inflammation. So as you can see, the passages for emptying of the sinuses are quite complicated. They empty to middle meatus of a nasal cavity, but also from nasal lacrimal duct, of course, to inferior meatus. Some of them, they are emptied directly, and some in much more complicated way, for example, maxillary sinus via hiatus semilunaris. And some maxillary sinuses come in different sizes, from hypoplastic, with the floor of the sinus well above the floor of nasal cavity, which in this case was really good news for the patient for implant placement. With patients with long-standing and dentulous maxilla, we expect that there will be very little bone for implant placement, but in this case, very pleasant surprise. No sinus lift procedure needed because the sinus is hypoplastic. Also, sphenoid frontal sinus can be completely missing. This is a case in which left maxillary sinus is hypoplastic, but the right one is of correct size. And also the anterior recesses of maxillary sinus are worth your concern, especially if you work in implant placement area, because usually you would not expect maxillary sinus in the area of upper canines. But in this case, the anterior recesses are very well developed. Sphenoid sinus also can present with various sizes, from this hypoplastic sinus consisting of just two small air cells in the body of the sphenoid bone, to this very large sinus with pneumatization of the recesses, for example, in the clinoid processes or in the pterygoid processes of the sphenoidal bone. Haller cells are also one of more frequent variations of sinus anatomy, and appearing in the upper portion of maxillary sinus, they contribute to elongation of infundibulum, so the way out from the maxillary sinus, which may lead to congestion. And at the same time, we are wondering probably why such a big sinus is drained by this small hiatus going moreover up. The question is, the answer to this question is fairly simple, and it's just our ancestors and its development. So in animals walking on four, the drainage of maxillary sinus goes the correct way, down according to gravity. But in humans and in apes walking on 2 feet, the evolution did not proceed that fast. So that's why the draining passage still goes up. And this, of course, contributes to so many sinonasal infections. Another type of commonly found variation is pneumatization of middle concha, and this is called concha bullosa, so like air cell in this turbinate, middle turbinate of a nasal cavity, often with asymmetry of a nasal septum and nasal cavity. Sometimes inflammation can be found also in this air cell. And septa, we do know that there are septa in maxillary sinuses, thicker or thinner, usually not complete, and they can be problematic. Like in this case of a young female who was referred for periodontal treatment, and she had what was classified previously as aggressive periodontal bone disease. Now it's classified as periodontal bone disease with location predominantly at central incisors and first molars. So the surgeons qualified this upper first left molar for extraction due to presence of vertical bone defects and reticular cyst. But the periodontologist requested CBCT scan, and in CBCT we found out that the image in panoramic was really tricky. There was just a septum in the sinus, which on panoramic looked like reticular cysts. So in this way, the periodontologist saved patients a tooth and proceeded with regeneration therapy. Having a look at this panoramic radiograph, can you see anything more specific? Yes, of course, the patient has sclerotic lesions, the periodontal bone disease, second premolars missing, but this is following orthodontic treatments. Root resorptions also following orthodontic treatments, but I bet you don't see what I am seeing. And to be true, I didn't see it in the panoramic when I reported it for this presumed reticular cyst. I found it in CBCT. There's just a very nice enamel pearl. Okay, so this was the first example of pathology. Let's move on to other examples of pathology. And that's a patient with cleidocranial dysplasia. She first visited us, well, back in 1990s. At that time in the department, we could offer her just panoramic radiograph, moreover, analog radiograph with not too much quality, but we do see her problem. In the area of maxillary sinus, we've got numerous impacted teeth, some structures that just resemble teeth, and no proposals of treatments were offered to the patient at that time. She reappeared at the time when we had our first CBCT machine, large field of view machine. We took the scan, and I remember that at that time, probably until now, it's one of the CBCT reports that I've been working on for the longest time, I would say, like maybe 1.5 hours. I tried to report all the teeth so that the surgeons know where they are. I was thinking how to name individual tooth. Some of these structures were not teeth exactly, but just calcified tissues. And at the same time, you can see that all these pathological teeth are located in the bone where maxillary sinuses should be. And the sinuses are very hypoplastic on both sides. One of the most common pathologies of paranasal sinuses are infections. And the signs and symptoms are fluid level, for example, change of sinus outline, also the opacity, the shape of this opacity. And this is a diagram showing complete opacity, fluid level, mucosal thickening, and mucosal polyp. However, once I was confronted by a radiologist who is also anatomist, and he made a very good point. Of course, we do say it's mucosal thickening because at 99% or more, this is thickening of mucosa. But he asked me, if you don't have CT scan, if you don't measure Hounsfield units, if you just have plain radiograph, how do you know it's mucosa? Empirically, yes, but at the same time, he was right. It can be a small infiltration, for example, from cancer that we cannot differentiate with radiographs and even with cone beam CT until it grows bigger and produces more clear signs of pathology. For acute sinusitis, I listed here the signs and symptoms in radiology. However, clinical presentation of the patients is so clear that mostly we do not refer the patients for diagnostic imaging. But of course, if we do take a radiograph and signs and symptoms are visible, we must report them. One of them is, of course, fluid level that depends on the patient's position during radiography or CBCT or CT scan, so it will look different in a patient lying down for medical CT or standing or sitting up for CBCT, or with head tilted 30 degrees up, like for this Waters view image. This just testifies to the fact that the fluid liquid is mobile and follows the rules of gravity. And this is example of the fluid levels in cone beam CT. And please remember, if the fluid is very sticky, very dense, it will also follow the rules of physics. So the shape of this level will be concave. Sometimes we see bubbles of gas in the fluid within the sinus. And again, with cone beam CT, without Hounsfield units, I am not 100% sure this is pus, but with this sign, I'm convinced this might be purulent exudate in the sinus. Medical CT, apart from demonstrating all these signs and symptoms, also allows evaluation of contrast enhancement. In this case, the enhancement was the strongest in the surface of mucosa. So this means that the mucosal thickening was concentric, and the main inner portion of the sinus is filled with mucus, and a little bit of just a bubble of air in the sinus. On the right side, the opening of the sinus is patent. Another example of medical CT, bone window, soft tissue window with pansinusitis of maxillary sinuses, ethmoid cells, and also fluid level in frontal sinus. With chronic sinusitis, the signs are less pronounced than in the acute phase of inflammations. We still can observe mucosal thickening, formation of secretions, pulps, sometimes mucosal polyps form with very long-standing inflammation. Sclerotic reaction from bony walls of the affected sinuses may proceed, leading to thickening of the sinus walls. And this is, of course, very frequent finding in panoramic radiographs in maxillary floor with presumed mucosal thickening. I must confess that since this comment from my colleague radiologist back in 2018, I reported as soft tissue thickening, not mucosal thickening, just in case. And mucosal thickening is evident also in cone beam CT as well as in MRI. I remember when I was a young radiologist back 20-something years ago, we had a very good Polish textbook, and one of the sentences concerning the sinuses was that sinusitis does not occur too frequently in, sorry, in sphenoid sinus and in ethmoidal cells. But now that we use cone beam CT in our diagnostics and previously CT, we do know that also these sinuses are affected by inflammation. It's probably that these mucosal thickenings were not perceived on Waters radiographs because they are just too thin. With long-standing inflammation, also the size of the sinus may be diminished, and as the walls will collapse. And in comparison, the left sinus is patent. I mentioned formation of polyps. And this is a very interesting case from my colleague orthodontist, a young male following orthodontic treatment. She found a strange radiopacity in panoramic radiograph looking like a teardrop. She referred the patient for cone beam CT, and we confirmed this very big polyp in the left maxillary sinus with just this tiny portion on which it was hanging from the roof of a maxillary sinus, and the patient was referred for ENT. With polyposis, the polyps will continue growing and they can grow out of the sinus from maxillary sinus, also invade, so like in this case, nasal cavity and go to the ethmoid cells. So this, of course, requires ENT intervention. And sometimes I would say some lesions are just too big. They are so big that we can miss them. I remember when I was still medical radiologist, young one, but teaching medical students, I was telling them, when you look at a radiograph, like chest radiograph, at that time put on a light box, don't just stare at this radiograph from very close distance, take a look from afar. And this is an example where you have to have a look from afar. This is a simple case. The patient referred for implant planning at the time when we had just a big field of view machine. Maybe now we would go for two small field of view, one medium field of view, but at that time it was large. And the patient had a lesion which could have been missed if we watched just the teeth and focused on implant placements. The patient had choanal polyp. It was really big, hanging from posterior nostrils, blocking most of upper airway of the pharynx. It was also stuck against the uvula, the soft palate, and the posterior wall of the pharynx. So some things are so big that we can miss them when focusing on small lesions. One of important types of sinusitis is fungal sinusitis, which comes in different forms. It can be eosinophilic allergic fungal sinusitis, a non-invasive form, and also invasive form with intraorbital and intracranial involvements. And in CT, we've got hyperdense lesions in the sinuses, and in MRI, the lesions with enhancing mucosal rim, like in this case, and also the lesion encroaching the nasal cavity. For cysts in maxillary and other sinuses, we have the intrinsic ones arising from the sinuses and extrinsic, so mostly odontogenic cysts entering the sinus from the outside, like radicular, residual, or dentigerous cysts. One of more common findings will be, of course, the mucosal retention cyst, due to blockage of mucus secreting cell from tiny to filling the whole antrum, which is well-defined opacity against the air shadow in the sinus, dome-shaped. This is the same patient in panoramic and in cone beam CT. Another example of dome-shaped lesion with no alteration of the outlines of the sinus, and also some mucus retention cysts with very high signal intensity in T2 images in MRI. Odontogenic cysts can also enter the sinus. They raise the floor of the sinus. They also contribute to resorption of the floor and thinning of the sclerotic rim. And there's displaced for a floor of the antrum visible. A typical case of reticular cyst around upper molar with raising of the floor of the sinus. And as normally we learn about the cysts that they are radiolucencies because they are against the contrast, the background in the bone. But once they enter the sinuses, the contrast with air in the sinus makes them more radiopaque. And another example of reticular cysts of upper molars, the vicinity of upper posterior teeth with maxillary sinuses contribute to a large percentage of inflammations in the sinuses. Some authors say that up to 20% of inflammatory lesions in the sinuses can be due to periapical lesions in the posterior upper teeth. And there is an example of reticular cyst, but with no sinus pathology otherwise. Follicular cyst, in this case, the germ of upper left third molar was displaced high into the sinus, surrounded by very large cyst, which again is radiopacity against the sinus air. And this is an MRI scan, which was reported by medical radiologist. Okay, I'm also a medical radiologist because there is no specialty in dental maxillofacial radiology in Poland. So I'm very happy for you that you have this specialty in Turkey. So many specialists and also your society. In my country, there are just a few people who deal with this professionally and only 4 departments of dental maxillofacial radiology among 10 dental schools. Of course, we do have less dental schools either than in Turkey. So I'm not saying everything about my colleagues, medical radiologists, because this is my main training, but they don't know too much about dental maxillofacial radiology. If they see any cyst in the jaws, they say it's radicular. If they see any tumor, every tumor will be amyloblastoma. If they see an extraction socket of third molar, they can report it as cancer, infiltration, and in this case, follicular cyst of upper molar in the maxillary sinus was missed. And I like this image very much because the tooth is heart-shaped with no signal, surrounded by a high intensity of fluid in T2 coronal image in MRI. And this is a patient who was referred for panoramic radiography by his family dentist because his dental prosthesis, removable prosthesis in the maxilla, did not fit anymore and he felt pain on using it. So he came for panoramic radiography and I saw this lesion, which is quite nicely limited from the side of maxillary sinus, dome-shaped, so could be mucus retention cyst. But when I looked at the floor of the sinus and the marginal alveolar process, I was really scared to death because the lesion was infiltrating and destroying the alveolar process. And since this is a very close person to my family, then I said, oh my God, I know this person, he has so many comorbidities and maxillary cancer is the last thing I would diagnose in him. So we did cone beam CT. It confirmed destruction of the bone. It looked like resorption of outer cortex of alveolar process in anterior area of the lesion, thinning of the cortex in posterior parts of the lesion, and not much expansion in buccal-lingual direction. The patient later had CT, and much to my relief, the lesion was reported as not enhancing very strongly, so it testified against cancer, and the bone was reported to be thinned but intact. And after excision, it turned out to be a odontogenic keratocyst, later in follow-up without relapse. For trauma, we've got all sorts of trauma in maxillofacial and CT is one of the main modalities, because when patients are brought to hospital to emergency, often with polytrauma, they get CT immediately, even in emergency, not only in radiology departments. So for sinus trauma, CT is superior to cone beam CT because the patient can be examined lying down on radiographic table, so even unconscious patients can be diagnosed. Bone and soft tissue window can be obtained both for lesions in the bone, but also for evaluation of soft tissue injuries. In this case, a comparison of blowouts, typical hanging drop appearance and Waters view, but much better visible in medical CT. And nowadays, CT scans are very fast with these multi-slice, multi-row spiral machines, so the imaging is even faster than in cone beam CT. I will show you a few cases from my very good friend, medical radiologist, Dr. Luisa Grzycka-Kowalczyk. She works in a clinical hospital. She has a lot of night duties and therefore a lot of interesting cases that I do not have nowadays working just in the dental school without emergency. For zygomatic complex fracture with disruption in the processes of zygomatic bone, the transposition of a broken fragment can be quite large. It's also called tripod fracture, as the three legs of the bone, let's say, are fractured and displaced. Nowadays, the classical classification of maxillofacial trauma, according to 19th century French surgeon René Lefort, is not as useful as previously, as it was based on analysis of patients who were mostly hit in the face by some hard objects. Nowadays, with patients suffering from maxillofacial trauma due to car accidents or falls from considerable heights, these fractures become more and more complicated. So we can still observe, like Lefort 1, the pyramidal, Lefort 2 fracture or craniofacial disjunction in Lefort 3 type. But this is one of the most dramatic cases I got from my friends. This was a young motorcycle rider who was driving too fast and hit a tree. So these axial slices already demonstrate the immense extent of the trauma, but when we go to the pseudo 3D reconstruction, now you can understand the previous axial slices. The maxilla was displaced very high up, rotated, so that's why you could see the teeth between the orbits. The patient tried to survive, has struggled for 1 month in intensive care. Unfortunately, he died following a secondary infection. Some of the injuries to maxillary sinuses can be inflicted by surgeons, by dentists, for example, oroentral communication following extraction. Let's move to the tumors. Benign tumors are far less common than the malignant tumors. And those that we do see are osteoma and inverted papilloma, which in MRI has this quite interesting and characteristic convoluted cerebriform pattern, which represents alternating lines of high and low signal intensity, but sometimes just remind us of the cerebrum, of the brain surface. And this is a case courtesy of Professor Kamor Han, and we can see an inverted papilloma in the left maxillary sinus and going into the nasal cavity and ethmoid cells with CT and with MRI. Osteomas are benign tumors made of mature bone tissue that are found frequently in frontal sinuses with different variation. This is a very sessile osteoma. Fibroosseous lesions, which are neither benign tumors, neither malignant tumors, can also affect sinuses. And one of more common will be fibrous dysplasia with expansion of the walls of the sinus. The image reported as orange peel or ground glass appearance. And in this case, the patient with a sclerotic form of fibrous dysplasia with a large expansion of the bones, and one of the major problems in these patients, which is narrowing of bone canals for the nerves and blood vessels. Tumors in the sinuses are tricky because when small, they can be completely asymptomatic, and once they become symptomatic with swelling of the face, destruction of the facial bones, the staging is very advanced. So this is one of these very advanced cases with large swelling of the face and enhancement following contrast administration with just congestion of fluid in the rest of the sinus. Apart from cancer, also sarcoma may affect maxillofacial area and the sinuses. This is a case also of a fairly young male in whom very aggressive osteosarcoma led to his death, but also invaded maxillary sinus with large soft tissue lesion and sun ray appearance and pathological calcifications. This young lady was far more lucky. She had chondrosarcoma, which is a little bit less aggressive than osteosarcoma. And following resection, she survived over 5 years after excision, and then she was lost from our follow-up. And as mentioned in the beginning, diagnostic imaging is also very important in the demonstration of perineural spread of cranial maxillofacial tumors along the cranial nerves. However, the time limits of my presentation do not allow me to go on for a very long time on that subject. The remaining examples of pathologies are some foreign bodies in the sinuses, also some of them inflicted by dentists, like fragments of tooth roots pushed into the sinus during extraction. Another case of tooth roots long time after extraction, the patient already during orthodontic treatment to close the gap, and this radix found in the sinus recess. A whole tooth in CT together with reticular cysts, so things happen. And this is the case of a filling material, the image, the shadow cast over the sinus, and the same patient 2 years later, so the image did not change considerably. And this case convinced me that two-dimensional radiographs are really tricky, and it's very difficult to rely on them, especially on panoramics. In fact, a few years ago, I started telling in my lectures that panoramics lie. These are panoramic reconstructions from cone beam, and two very similar cases of overfilled material. This one looks like outside sinus because it's outside the focal plane, a little bit enlarged in the horizontal dimension, and this one looks like a foreign body in the sinus. We can see even the sinus wall in here. But when we take a look at cone beam, this foreign body was in the sinus, but this one was outside the sinus. This is the wall we could see, but the material was completely outside the maxillary sinus lumen. And this is one of recent cases. When I look at things like that, I'm just sometimes wondering if a dentist performing this endodontic treatment doesn't look at this table and doesn't think, where does all this material go? Okay, so where did we go? We went 1 hour into my lecture. I don't know if I can continue for a little bit more. Mert?
You can proceed. We're
okay. Not much left, but I would like to say a few words about these incidental findings. And many associations in their guidelines state that incidental findings must be reported, all of them, the clinically relevant as well as incidental findings. But the prevalence of pathological findings in maxillary sinus and cone beam CT has been studied extensively. And they do occur quite often. You can see in this study over 1/3 of sinuses presented with mucosal thickening. This will not be a scientific observation. This is my personal observation. At this time in Poland, when I report CBCTs, I find mucosal lesions in almost every single patient, because with all this terrible weather that we are having right now in Polish winter. But in summer, it's the opposite, only a few lesions in the sinuses. So the reporting time for large field of view CBCT is shorter in summer than in winter. For incidental findings in CBCT studied by Turkish colleagues, the conclusion was that while most incidental findings require no treatment, some conditions will necessitate modification of a treatment plan. So underlining the importance of finding these lesions and reporting them. And the dentists and radiologists should be aware of these incidental findings and comprehensively evaluate the entire sinus. But how do we evaluate the sinuses? This is a very interesting study that compared radiologists with endodontic residents. So the radiologist reported 87% of incidental findings, not 100%, okay, but 87%. The endodontic resident only 50%. So this means that the human eye must be trained sufficiently enough to see what can be found in the sinuses. Also, the clinical efficacy of main radiologic diagnostic methods for odontogenic maxillary sinusitis was compared between dental, ENT, and radiology specialists in computed tomography, as well as intraoral and panoramic radiographs. So the highest inter-observer agreement was observed between the experienced oral radiologists and ENT surgeons. So once again, the importance of the training of a human being. Okay, human beings, are we still needed in radiology? This machine learning, artificial intelligence, it's hype, or is it our future? Regarding many studies on AI, I found this one on deep learning for diagnosis of paranasal sinusitis using multi-view radiographs. And the conclusion from the study based on Waters' view and Caldwell view of the sinuses resulted in the conclusion that the deep learning algorithm prepared by the authors was able to reliably assess frontal, ethmoid, and maxillary sinusitis on Waters and Caldwell view radiographs, and the algorithm outperformed the radiologist for ethmoid and maxillary sinusitis. So are we still needed? Well, just before COVID, this funny image came via WhatsApp. And in fact, it was a series, how to be a radiologist, how to be a dentist, how to be a surgeon, etc., etc. So how to be a radiologist? Can you see anything in radiograph? Yes, then you're right. The finding can correspond to this, or this, or this, then click, the report is ready. If you don't see anything in the radiograph, you still can say that this or this cannot be excluded. Then you press enter and the report is ready. So with this, I would like to thank you very much for your attention. And you are most welcome to my home city of Lublin in Poland. In this year, I was supposed to host European Congress of Dental-Maxillofacial Radiology, but unfortunately, due to COVID, it will be held online only. In about 2 weeks' time, we will open the registration for the Congress, so please check out the websites of European Academy of Dental-Maxillofacial Radiology and of the Congress in just a couple of weeks. And you are most welcome to my city, even if online only. If you have any questions, you can probably ask them now in chat. If not, you can also write me on by email. And those of you who are my friends on Facebook, many of them, you can also write me on Messenger, on WhatsApp, etc. So once again, thank you so much for your kind attention.
Thank you, Professor, for your lovely speech. Before we end up our lecture, Professor Kaan Orhan was away. I hope he catched a bit, but he sends his regards. Professor Özlem Özlem Hoca sends you regards, says, dear Ingrid, thank you for your interesting presentation. Seni görmek ve dinlemek çok güzel, çok sevgiler.
Teşekkür ederim.
And lots of our professors sends thanks and best wishes. Okay. Buyurun hocam. On the behalf of our society, on the behalf of our community, we thank you for your speech. Professor Ingrid Rozylo wants to say a little bit of words. Buyurun hocam. Hocam mikrofonunuz kapalı galiba. Hocam aşağıdan mikrofonunuzu açın lütfen. Evet.
Açtım. Thank you, Ingrid. How are you?
I'm fine, thank you. Çok iyiyim.
Teşekkürler bizde. For your presentation was amazing.
Çok teşekkür ederim. Ben çok memnun oldum.
Ben de öpüyorum seni.
Ben de öpüyorum.
Çok öpüyorum.
Görüşmek üzere.
Yeah, thank you. Görüşürüz. Evet.
Before we go, I have a question, a couple of questions. One is asking for how can we differentiate invasive fungal sinusitis and malignancy?
Yes, and? So this is the first question, yes?
Yes. The other one is from Guillermo Conca. Thanks, Professor Ingrid. Is normal 1 or 3 millimeter thickened mucosa in the maxillary sinus or not?
Sorry, can you please repeat the second one?
Is asking for the thickening of mucosa in the
yes.
sinus, asking for the millimeters of thickening. But
okay, the millimeters.
It's pathological when it's.
So it's difficult to say because there are different views on that. For example, I found a statement saying that up to 4 millimeters it's normal in maxillary sinus, but 4 millimeters will be already abnormal in the ethmoids and the sphenoid sinuses. For children, the mucosa should not be visible in the sinuses at all. But regarding this 4 millimeter limit for maxillary sinus, some say that it's too much, that even smaller thickening is already considered pathological. But myself, I stopped reporting normal, abnormal. I started just writing the thickness of the mucosa, and then for example, for the follow-up, you can compare if lesions recede or if they progress in the patients. And for the first question, yes, of course, it's a very good question for fungal sinusitis and differentiation between cancer, because you're right, in invasive form, it can resemble carcinoma, as it leads to erosion of the bone, and also it's hyperdense in CT with expansion. However, with MRI, T1 and T2 will be low signal intensity in the fungal sinusitis, and the contrast enhancement will be just the mucosal rim. And in cancer, we know that the lesions enhance very heterogeneously, not just mucosal rim, but the interior of a region, of a lesion.
Thank you so much. Andrea, Dr. Leite, thank you very much, Professor Ingrid, for your valuable presentation. Dr. Esra Yeşilova, dear Ingrid, thank you for your enriched presentation with interesting cases. Farklı vakalarda zenginleştirilmiş sunumunuz için teşekkür ederiz. Sena Gül Kılınç, dear Professor Ingrid, so thanks for this presentation. And I have lots of thanks and greetings. I'm not gonna take your time to
That's right. So
all of them.
thank everyone for all of
Professor
them.
Tamer Lütfi Erdem says thanks. Everyone says thanks and greetings. Thank you again for your time, for your effort, for your valuable information about the topic. Thank you so much, Hocam.
Pleasure is mine.
Thank you.
The pleasure is mine, and you are all most welcome to our online lecture. But anyway, you are also welcome to Lublin if you want to come visit. If you want to come with, for example, Erasmus, we now have this bilateral agreement with Ankara University. But if there is any other possibility of international cooperation, you are all most welcome to visit us.
I have one more question for you before you leave from WhatsApp message. How can we differentiate with using CBCT from acute bleeding to the maxillary sinus, inside the maxillary sinus, or sinus pathologies by using CBCT?
No,
bleeding
with CBCT, no, because as I mentioned, the Hounsfield units estimation is not as precise as with computed tomography. In CT, the Hounsfield units for acute bleeding are like 70, 80 HU, and they are much higher than the fluids. Like clear fluid is about 0 for Hounsfield units. More dense fluid will be around 20, and the blood will be much more hyperdense. Unfortunately, in the cone beam CT, still, despite many technical developments, the estimation of the units is with standard deviation of hundreds even of units. So when we think that basic scale of Hounsfield is from minus 1024 to plus 1024, and extended is to plus, let's say, 4000 for the hard tissues, for the bone, for the teeth, then this portion of the densities, which is limited to soft tissues, it's not a large portion of the scale. So in CT, even if in CT we do have this error in estimation of the Hounsfield units, but it's not as large as in cone beam CT. So at that moment, okay, we can probably suspect that it's a patient is following trauma. What we see in the sinus is bleeding, but it may be just comorbidity. It may be coincidence that the patient had sinusitis before the trauma. So no, at this moment, no. CT will be far better for that purpose.
Okay, that question was from Professor Sinan Orasan, and he sends you thanks.
Same to Sinan.
Professor Azdamakmush sends thank you for your great presentation. Professor Filiz Pekiner sends thanks, and lots more. Thank you so much again.
I thank you all.
Have a good night. Thank you. See you later.
Çok
Thank you so
teşekkür
much.
ederim. İyi geceler.
İyi
Görüşürüz.
geceler. Teşekkürler.
Bye bye.
Değerli